All right, well, let's get started here. So, again, my name is Bryce Robinson, and I am the chair of the East Practice Management Guideline Committee. I really want to, again, thank the online education group for putting the time and the effort to get us all on the same page to create these short 10 to 15-minute talks to help people out with their PMGs. We have noticed that we can only do so much, and there's different sort of formats to help people understand how to read, write, and participate in our East PMGs, and we're hoping with the help of the online education group that we become more successful. So I was asked to put together kind of this idea of how do we get these papers published? What is something about their format? How do we organize people onto the same page to write an East PMG? All the hard work is done, all the data is extracted. How do we actually write the paper? And so the next 10 to 15 minutes hopefully will give some clarity on what we do and what we try to repeat in an organized fashion for these East PMGs. I have no financial disclosures to report. The goal of this talk is really I want to review the format of our East Practice Management Guidelines. Why are they put into a very particular order? Understand how the author instructions from the Journal of Trauma impact the writing of our PMGs, and then kind of introduce the viewer, the reader, to the National Guideline Clearinghouse, which we also think is a really important sort of end goal for writing our East PMGs. So in 2012, East made a very concerted effort to convert how we write our East PMGs, and in that year we decided that we were going to find the grade methodology for all the PMGs going forward. That is a really difficult sort of undertaking because at the time there were only a handful of East members that had any experience with grade. Even less had expertise in grade, and so we kind of had to kind of start all over from scratch, create a group of people that understood grade, felt comfortable teaching grade, and then had them participate in our PMGs. We got that group together, and when we got critical mass in about 2015, we sat down and said, listen, we need to write a white paper of how to write East PMGs. The common problem is that people sit down, they're very excited about the subject material, they get an author group together, and everyone scratches their heads and says, okay, now what? And so we felt like by creating a white paper, we can give people 1, 2, 3 steps of how to write an East PMG from the very beginning to the very end, and we put that on our website. So if you go to the East PMG section of the East website, that white paper is there in a PDF format. You can download it. Very truthfully, it's 70-some pages, so it's a very thorough document, but really we wanted to create something that had a lot of detail so that if people have very specific questions, hopefully they lay within that document. So the Journal of Trauma is really important for East. I think we have created a very strong, mutually beneficial relationship with the journal, and when we sit down and we write our PMGs, we're really looking to put them in the Journal of Trauma. So we follow the instructions to the authors very, very closely. If you read our white paper, like I just discussed, it really kind of highlights how our East PMG subject material can fit into their recommendations and how we go forward. The relationship with the Journal of Trauma is so strong that every East PMG that is published, they actually put on their web page for free under the collections section. You can see that down tab there at the lower portion of the slide. And that's really important for multiple factors, but the one I think is a little bit self-serving is that when East wants to do an online journal club, or if they want to do some sort of online education, nobody has to pay for the PMG. No one has to download the PMG from PubLed through their academic institution, but instead we can direct them to the web page, and it's accessible to anybody in the world. So that really gives us a lot of visibility for people as they take care of the injured patient. It gets kind of confusing for some people to understand, well, what exactly am I writing? Am I writing a practice management guideline? Am I writing an evidence-based review? And what I tell authors is that if you are going to apply grade to a very specific clinical problem that you are going to someday read the PMG, go to the patient's bedside and say, we're going to do this because this is what their recommendation says, that's a practice management guideline. If you are writing a somewhat more larger social topic, topic or a social issue, it's not just limited to patient care. That's probably going to be an evidence-based review. The group that writes probably the most of these, the task force that really has to understand the difference between the two, is the group that's writing injury prevention sort of work. These are, again, larger systems or social issues, and these fit nicely within the guidelines, or at least the author instructions from Journal of Trauma for an evidence-based review. Like a previous talk I gave, it's really important before you sit down and write any of these PMGs, you got to know the subject material, not as a subject expert, but at least understand that yes, there are papers that exist that can possibly answer our question. Not well, gosh, this is a really hard question, we should answer it for people, because you would be surprised if it was easy to answer, people would have written papers on it. So just realize that there has to be literature that exists for your particular question so that you can try to answer it. If no literature exists, you're not going to really have the ability to synthesize it and create a recommendation and a guideline. I tell an author group, and this is really important, to stick to 3 or 4 specific PICO questions and their various outcomes. Any more than 3 to 4 questions, and it's hard to tackle a project. The Society of Critical Care Medicine, when they put their guidelines together, they have 10s and 30 PICO questions. We cannot do that. We do not have the resources. We don't have paid resources to help authors like FCCM does, and we just don't have the space within the journal to publish really long guidelines. 3 to 4 PICO questions seems to work for us, for our volunteer-based group, and for the editorial board of the Journal of Trauma. When you have really a big PMG with lots of questions, it becomes really large and vague, and the project will fail because there's a really kind of a lack of direction. So narrowing the topic to 3 or 4 questions, I think, is the way to go. We have written PMGs within the last year where there's a single question, and I think that really helps people, especially if that single question has a lot of literature surrounding it, then by all means, let's just focus on that one question. So why do we do 3 or 4 questions? Well, if you go through the instructions for the authors for the Journal of Trauma and you look at what they're recommending for systematic reviews versus guidelines, you can see that the figure and table limit is between 6 and 8, depending on what PMG or / review you're going to write. And that's really, really important. So if you're limited to 6 to 8 figures, how does that play out if you have a certain number of questions? So I tell people is 3 or 4 PICO questions fits nicely within the restrictions of the journal, because the first figure that you're going to write is going to be your concert diagram. And the concert diagram shows the reader exactly what papers you found and which ones were included and which ones were excluded. So if you have the ability to write 8 figures in tables in totality, you're down to 7. All right, so every PICO question will require an evidence table, and that's generated through the software within the section. So every question, if you have 3 questions, that's 3 tables. Now you're down to 4 total. Every PICO question, if you can, should also have a forest plot. And that's done within RevMan. So if you have 3 questions, that's 3 more figures / tables. You're down to 1 final sort of table, and we say we want the last figure / table to be a summary of the recommendations. And so if you have 3 questions, you can see how you're really sort of limited already on what the journal will take in terms of figures and tables. When we used to write the old recommendations, it was kind of easy. And if you read back through anything that was written by East before 2012, they had the classes of evidence and they had the level of recommendations. And the classes of evidence were 1, 2, 3, and they were based on the highest class, being class 1, was prospective randomized controlled trial literature, versus class 3, which is traditionally retrospective data, which is much easier to come by within the surgical field. And based on the classes of the evidence, groups would make their level of recommendation. So we'd say level 1 recommendation, level 2 recommendation, level 3, etc. And you can see that in this format, the level of recommendation is very much linked to the class of evidence. So if a recommendation is deemed level 1, it is convincingly justifiable based on class 1 or class 2 data. And then it goes down from there. Level 2 is weaker sort of a recommendation based on weaker class data, and et cetera, and et cetera. Things changed dramatically when we did grade because we really sort of abolished that sort of system. Grade is very different in that it looks at the totality of the literature. So if you're looking at a very specific question, you are going to review all of the body of literature for that particular question. And then you're going to express to the reader in a very transparent way the quality of that particular literature. You are working to avoid expert opinion. And if you go back, expert opinion was part of the process of level 1 and level 2. In grade, we make a very dedicated effort to avoid expert opinion. There is a distinction with grade between the quality of the evidence and the strength of the recommendation. That is not true in the old system. In the old system, if you had very high quality literature, you would have a very high level of recommendation. Grade doesn't do that. Grade doesn't link those two. You can have very weak literature and a strong recommendation for a variety of reasons that we'll go into. So it's a very different sort of methodology. And then finally, grade tries to create actionable questions. Your question is an actionable question, and your recommendation is going to be actionable as well. You're telling the reader what you think they should do versus a very vague sort of question that was commonplace in the old system. So the new grade methodology, like we talked about, can account for poor quality of evidence. Though you may have a randomized controlled trial, it can be pretty lousy, and grade will let you downgrade or downscore that literature to change how the strength of the recommendation. Old system, you couldn't do that. Recommendations within grade also keep in mind other very, very important variables within creating a recommendation. Specifically, what is the benefit versus harm of a particular intervention? This was not considered in the old system. It also includes the values and preferences of the patient. And I will tell you, the more I do this, the more surprised I am at the difference between what the physician groups thinks people should do and what the patient, when you actually interview them, and what they think the recommendation should be. So these, again, grade takes into account this sort of values and preferences, which before wasn't in the literature. It also takes into account feasibility, the acceptability, really sort of all these other sort of pieces that we know in the back of our mind when we're giving patients advice, we are doing in our mind, but this actually spells it out. And it also includes the idea of cost or resource utilization. So a recommendation is going to take all these things into account and package the recommendation, having that information built within it. And like I said beforehand, grade allows for weak evidence to be a very strong recommendation because of these other factors, the harm versus benefit or the feasibility, etc. The other system, the old system, didn't let us do that. So when we, aka East, writes a guideline, we try to keep our language the same since about 2014. And so if we have a quote-unquote weak recommendation, we will say we conditionally recommend for or against a particular intervention. If we at East have a strong recommendation, we will literally say we recommend for or against. And that language hasn't changed since, again, 2014, 2013, and our goal is to continue that so we're not creating confusion when people pick up our PMGs. It's very clear where we stand on a particular recommendation. A strong recommendation does have its own sort of importance behind it, in that a strong recommendation may change policy and may become the new standard of care. So when we make a strong recommendation, we take into account that by saying such, that this is really important for the community as a whole to do what we're recommending. And so those recommendations are not provided lightly. This is kind of, unfortunately, a busy slide, but when we write our guidelines, actually type them up, we have a very specific format, and this format is listed below. We do want to include an abstract. We have an introduction of the topic material. We want to list our PICOs. We want to give the reader the idea. This is how we did our search strategy within the various sort of electronic platforms to find the papers. The goal is that somebody can pick up our paper and say, I'm going to do the same search strategy and find exactly the same papers, and that's why we produced that. We defined our outcomes, so what are the various outcomes for the questions? We're very clear with how we got to there. We do it by voting, and we'll explain how we do the voting. We talk about how we get the data out and what kind of methodology or what resources we use to extract the data, specifically the software, algorithms, etc. And then we will give results for each individual PICO question. We summarize the key papers within the qualitative synthesis, and if we're able to do a meta-analysis, you'll see us do a quantitative synthesis. We will grade the evidence with all of those different variables we talked about a couple slides ago, providing an evidence table to justify that grading, and then we will produce a recommendation. And we do that for every PICO question, and then at the very end of the paper, we are asking authors to really write a section about how they can put these guidelines into clinical practice. I can't tell you the number of times I get people calling me or sending me emails saying, yeah, I got it, I read your PMG, just tell me what to do. Grade doesn't really want us to do that, but I think there is a practical aspect of taking a PMG and adjusting it for your practice or for your institution. And so we have authors really spend a little bit of time and say, this is how they would take this PMG and put it into practice, at least at their institution. And then we spend the last couple paragraphs trying to explain what we think are future directions for the subject material. By doing this big literature search and being very well organized with the various papers, we can tell you pretty quickly what is out there and what is not, and by writing this section we're letting others know where the sort of holes in the literature are, and then we provide our conclusions with recommendations and et cetera, and you can see the rest. So again, we try to write the same sort of format over and over again so that somebody can pick up a East PMG over the last couple of years and say, this is how it's organized, I feel comfortable reading this sort of way, not get bogged down with a lot of the methodology sort of verbiage, because again, we've already presented that in the past. We can avoid doing it in every single PMG and really focus on the results in the last final paragraphs like we talked about. The title of these PMGs, these are all roughly the same on purpose because, again, we don't want to confuse the reader. We want the reader to understand exactly what the subject material is about and then who wrote it. And again, you fill in the blank, but at the end it's going to be a practice management guideline or an evidence-based review from the Eastern Association for the Surgery of Trauma. We do provide abstracts. These are optional for PMGs, but we feel like it helps the reader to really kind of quickly assess whether this is important for their practice or not. The Journal of Trauma restricts that limit to 300 words, and we follow that. We provide 3 to 5 keywords, and then, like I said, one of the things we really want our writers to perform is a very final figure or table summarizing all the recommendations. This is exceptionally helpful if you're looking at our PMG on a mobile device. You can get right to the very end and say, okay, what are the meat and potatoes of this PMG? How is it going to change my practice? Even though you put the paper in, you're not done yet. The paper is done, so what happens at the committee level? So a final document that's been approved by the writing group gets sent to the committee. So the writing group within themselves writes a PMG. They follow the organization that we have spelled out in the how-to white paper, and then they send us the manuscript, their final manuscript that they've all agreed and reviewed and done all the important things to it. Then we take that PMG manuscript and we do a blind review, and that's done within the committee system. I really kind of serve as the editor-in-chief of the group, and then I find blind reviewers that are knowledgeable about the subject material but also grade to blind review the paper. They create comments. It gets sent back to the author group. They make adjustments based on that comments, and then finally, when the final version of the paper after it's been edited by the blind review of the committee gets created, we have the blind reviewers look at it one last time, giving a thumbs up or a thumbs down for submission. It seems like a cumbersome process, but I will tell you from all practicality, we have been very successful over the last 2 or 3 years with our submissions to the Journal of Trauma for being able to be published, and I think it's because to get to that point, we've already created an internal review process of experts in the methodology to identify problems before they are identified by the editorial board. So what happens after publication? So if you're fortunate enough, the paper gets submitted, it gets accepted. What happens next? You're not over yet. You can't pat yourself on the back quite yet. After publication, the National Guideline Clearinghouse will pick up on the PMG. The National Guideline Clearinghouse falls under the AHRQ, which is part of the Department of Health and Human Services. It's an online system, a collection of all of the practice management guidelines that are of high quality. I kind of think of it as the best of the practice management guideline world, and we really, really want our PMGs to be there. When they review your PMG out of the Journal of Trauma, they will generate a summary, and they allow the authors to review their summary. They will have questions or holes that they address within their summary that will need to be a focus of the author group. So we send those to the primary author/author group, and they confirm what the AHRQ and the National Guideline Clearinghouse has written within their own sort of summary, and then we give them the thumbs up, thumbs down as to why we think certain things should be included or excluded. And it's a really nice relationship. The National Guideline Clearinghouse will not have a PMG on their website that is not updated every 3 years. So as a clinical practice trauma surgeon, if I'm looking for a high quality PMG that's current, or at least the literature review is current, this is a great place to go to find out what others are writing about or recommending. And for us, it means that if you're an author of a East PMG that's in the National Guideline Clearinghouse, every 3 years they're going to request that you do another literature review to confirm that indeed your PMG is up to date with the current literature, or maybe it's not and they have to remove it. After you write your PMG, you're the expert in the field, and I really believe this. And so what we'll do is we will call upon you to be a blind reviewer. You have spent a lot of time going through the process of writing and reviewing and understanding grade and putting it into the format that we like to submit to the journal. We're going to use that skill set to make you in our blind reviewer pool. If you have a high-quality PMG, you will be able to present it at the East Annual Meeting. We have our plenary session. It's traditionally on Friday afternoon, and in about 10 to 15 minutes, we want you to present your PMG and allow the East community to ask questions before it gets published. After publishing or during the publication process, you're going to be asked upon by East leadership to represent the group as the expert in that subject material. And the groups that are really interested in having your participation is the Society of Trauma Nurses. Is an opportunity to give a talk to them. The American College of Surgeons Committee on Trauma Process Improvement are oftentimes making best practice documents and statements, and our guidelines fit in nicely with what they're trying to do. So you may be asked to be a content expert on a best practice statement written by the COT. And there's other groups constantly looking for speakers about subject material, the Pediatric Trauma Society, other surgical societies and non-surgical societies. Regional meetings are oftentimes looking for speakers, and because of the wide appeal of East and their PMGs, oftentimes we're asked to provide a presenter about a particular topic, and that's going to be you. Well, that's what I have right now to keep the talk short. But again, I think it's a very doable process. We've spelled it out very clearly within our white paper. But again, if there's any questions, we really want to stress the fact that the committee and the task force of the guideline committee is there to answer questions, concerns, etc., for people that are writing PMGs or thinking about writing PMGs or just reading a PMG that they don't understand. We're here to help. We want to be available. Our emails and our contact information is obviously on the East webpage. Please, please, please reach out to us if there's any questions or issues. I want to take a special moment to thank, again, the online education group for allowing us to provide these supplements or videos to those within the East community regarding PMGs. We are biased. We think they're very important. But again, I want to take a couple seconds and just say thank you to Dave Morris and Joe Cantino for supporting us and supporting this effort. So again, thanks, guys.